So by now you are all expert on HT Supreme, so enough theory. I think we should go to the practice, Faisal. And Faisal will introduce a case which is HE death implantation in a high-risk bleeding patient.
So thank you very much for the invitation, and glad to be here. My job here is to present a case that we did in Galway University Hospital recently of a patient with high bleeding risk using the technology that is just described, HT Supreme. No conflict of interest for this presentation. So the case is of an 86-year-old patient who has multiple risk factors for coronary artery disease, is hypertensive, previous smoker, dyslipidemia. He's known chronic kidney disease, stage 4, and his GFR values have been around 28 ml per minute per meter square. He's chronic anemia, hemoglobin in the range of 10 to 11 grams per deciliter, normal platelets. He's been investigated currently for prostate cancer, but awaiting investigations, nothing's confirmed yet. So presented in 2022 April with ongoing angina, crescendo in nature, to emergency department. Troponin levels were marginally raised at 39, no significant ECG changes. He was treated as acute coronary syndrome, pro-BNP 450, and pre-test coronary artery disease was 87% based on the criteria that we used just now. So diagnostic angiogram was performed via right radial artery. You can see the calcified right coronary artery with minor atheroma in the proximal and the distal segment, dominant vessel. We did the left, and again, left main is normal, circumflex non-dominant with no significant disease, but there is a significant angiographic stenosis of the proximal LAD, which is diffuse in nature and appears to be more than 20 millimeter to 30 millimeter at least with the TIMI2 flow. The flow was slightly altered in the LAD. As per usual practice, syntax score 1 was 22. So you can do PCI cabbage. We did a syntax score 2 looking at the anatomical and clinical variables, which gives us a 4-year mortality of 22.7 for PCI and 25.8 for coronary artery bypass grafting. Despite the high age, the Euro score was low at 4.3. We had a heart team discussion because of a single vessel disease, higher age. PCI was recommended for this patient, but we were going to do physiology guided. So here we have used the criteria for high bleeding risk, and this patient had 2 major with renal failure and anemia and 1 minor based on age, and that gives him a risk of bleeding of 11% at 1 year. And we used the other criteria as well just here for demonstration, but patient was deemed as high bleeding risk patient, and we have to be very careful in terms of how we give antiplatelets to this patient. Patient was enrolled in the Pioneer 4 trial. This is a trial that is after we have done the diagnostic angiogram and patient is suitable for treatment. Patient was treated, randomized into either a QFR guided physiology, guided PCI, or a usual care. The usual care can be an FFR, an IFR, or based on just ECG and troponins. Physicians may decide to go ahead and do it because the patient is an ACS patient and does not need any further physiology. So we performed the QFR, which is the computational dynamics, flow dynamics, and this was positive for LAD at 0.448 with the QFR delta of 0.36. It tells us that the length of the lesion is about 30 millimeter, 29 millimeter to be precise, and 65% diameter stenosis with the QCA was around 2.6 to 2.5. We performed the same thing for the right, which was negative as expected, 0.93, and circumflex was also negative at 0.95. So here we have angiography and physiology, where we have single vessel disease, which is angiographically significant, also positive based on physiology as per the trial protocol. The proximal, the circumflex and the RCA were both negative. The plan was to go ahead and perform coronary intervention for this LAD calcified lesion. So we start looking at how we're going to treat it. It's severely calcified angiographically. Calcium debulking is necessary. Can we do lithotripsy? Should we do rotational atherectomy? And I think we decided to start with intracoronary imaging, and IVUS was selected for that reason. So here is the first image, CLS guide 3.5, standard workhorse wire cyan blue. We were unable to get the IVUS catheter across the lesion. Therefore, we decided to put in a 2.5 semi-compliant balloon, which was also, we were unable to cross it. We dilated it at the location to modify the plaque and see if we can get the IVUS through, and this maneuver was also unsuccessful. So at this stage, of course, the next step was to try and do rotational atherectomy. So that's where we get prepared. We continued with the 6 French. You can see the microcatheter that we normally use for exchanging the wires. So we have a cyan blue. We put the microcatheter through down to the distal LED, and then we put a floppy wire, rota floppy wire. This was not possible because the exchange catheter, which is the and we couldn't get that across either. So we had to just use the floppy wire, which has very little torqueability, and try and get it with the Dynaglide down to the distal LAD. We did a 1.25 burr, and after multiple burring, we managed to cross it and make it easy for us to place stent. Before we did that, we performed the intravascular ultrasound, which showed significant calcification confirmed on IVUS catheter. You can see that the calcium score was at least 3 to 4. There was more than 5 millimeter length of calcium. And there was ostial concentric calcification, and there was a significant calcific nodules, and we did see some fracturing of the calcium on the IVUS as well. So based on that, we started with some dilatation with a small balloon 2.0 and then up to 3.0. We used non-compliant balloons as well. We saw good balloon expansion. We placed 2 overlapping stents. The first one was a 3/0 by 30 HT Supreme based on the IVUS, and which again led to good expansion. So we were pleased with that. The second one was placed all the way up to the ostium. And we protected the circumflex, which was a non-dominant vessel. And again, we performed post-dilatation with a 4/0 non-compliant balloon to high pressure. So this is the more or less the final result. And it's not mandated in the trial to perform intravascular imaging, but for this case, we did perform it because of the amount of calcification. And we saw a very good stent expansion and no malapposition. So there were no further post-dilatation was performed in this case, and we achieved TIMI-3 flow as well. So stent expansion was more than 80% of the minimal stent area. You can see here that we have some eccentricity, but the stent is very well opposed. And here in the corner, you can see at the left main circumflex bifurcation that there was no plaque or stent protrusion into the left main. So nicely placed, and we achieved a good result. We always repeat the QFR, and you know from the trials that it has to be more than 0.91 to make sure that there is long-term better results, and this was 0.95, so optimal physiological results. And as per the protocol of the trial, we're treating patients with single dual antiplatelet treatment for 1 month, and after 1 month, patient stays on a single P2Y12 inhibitor for 11 months. And at 11 months, which is 1 year time, we stop that drug and restart aspirin. And this is based on all the evidence derived from the trials in the past. So if the patient has high-risk bleeding, normally our strategy is to give aspirin and clopidogrel for 3 months, and then after 3 months, single antiplatelet with aspirin. But if the patient is very high risk, we give DAPT for 1 month and then give them a clopidogrel for the rest of the year. So patient is doing very well at this stage. So this is, just to conclude, a new generation balloon expandable biodegradable polymer stents. We aim to promote vascular healing through early drug delivery up to 4 to 6 weeks. This is virtual PCI quantitative flow ratio guided construction of physiological map of all 3 blood vessels. And we also achieve optimal post-PCI physiology, which is recommended. IVUS guided to reduce the amount of contrast, calcium debulking strategy, and stent optimization. And finally, a careful evaluation of patients' thrombotic bleeding profile with the different risk score is mandatory for an adequate therapeutic strategy. Thank you.
Thank you, Faisal. I mean, Professor Sharif of Galway, it was a tricky case, you know, when you start at that age with a creatinine clearance of 28 ml and the prostate and many other things, was very tricky. I think the procedure was beautiful in terms of pre-treating this lesion. The assessment of physiology was also very important. One thing I would like to say, you said the Euro score is low. You have here a famous surgeon from Barcelona, Professor Pomar. He will tell you that 4.3% 30 days mortality is not a low score. You agree with that?
I fully agree.
Okay.
Oh, yeah, okay.
But he was gentle with the surgeon. He said a low score.